mitral valve, what do you think is going on with mitral stenosis? What's the whole concept of mitral stenosis? Give
S-
me a general concept of it.
Something's restricting the flow of the mitral valve.
Good. So just like tricuspid valve, just like pulmonary, just like aortic, like we've all covered, it's something restricting valve motion. So if you as an echo tech are going in, what do you think your primary objectives are to prove to me?
How
Specifically,
much
if we're
of the
looking
valve?
for mitral stenosis. Sorry, Kelsey, go ahead.
No, you're good. Go ahead.
We'll go Mike first and then Kelsey.
We're talking if we're only studying the mitral stenosis, if that's the key thing we're looking at.
So yeah, so first of all, you have some suspicions of something going on with the mitral valve. So again, just taking this broadly to start with, if you're showing me something about the valve, what do you want to show me? First in 2D, then M mode, then color, then Doppler.
Okay, so short axis, I want to give you the PAPs, I want to give you the mitral valve, I want to give you the apex, making sure all those are moving properly. Then I want to check in mode, I want to check the EPSS to make sure that it's properly bowing out. Color, I want to check to make sure there's no regurg or, well, I guess we're talking stenosis here. I want to make sure that where the stenosis is, so walking the pulse wave through it, like Tammy was talking to us, to better categorize where it's at, and then continuous wave to get the maximum velocity. That way we can check the pressure and that kind of thing.
Good. Kelsey, anything to add?
Yeah, and then as for measurements go, I would just do the E wave, the A wave, the A duration, the pressure half time, the decel time, if there's regurgitation, the PISA, the vena contracta, just all the measurements in addition to that.
Good. All right, so lecture's done for today and tomorrow. Just kidding. No, that's an excellent summary. That's great. And that is true. So when you go into labs, when we talk about competency exam, don't get super stressed about it. I do want you to take it seriously because it is serious. We need to look at having critical thinking skills that, if a doctor asked us to go and do something, or if we're going along a certain line and maybe it falls outside of our written protocol, you need to be able to know, what they're going after so that you can appropriately show them the images that would be relevant to what is going on. So, so good. So generally speaking, from a mitral stenosis standpoint, so we know that the cause or the problem of the valve is that it's not opening correctly. In 2D, what's relevant to us there? Okay, the narrow opening. Okay, so right away we're going to see it in our very first person long axis view, and every mitral valve view beyond that. So is it appropriate if you have a mitral valve study to show me all the views of the mitral valve? Definitely. We want to see it. So first we want to see it if it's opening or if it's closing and coapting properly. That is our first primary objective. So seeing the valve, so if I saw the valve open, so just throw a few hypotheticals out there. If I saw the valve opening and closing really well, and yet later on we get some mitral stenotic Doppler signals that are high velocity and stuff like that, would you be concerned about the valve structure itself? I see it moving well. Okay. If I see it opening and closing well, but then I get some Doppler, chances are it's something else that's happening. So if you saw it well in 2D, it doesn't diagnose everything perfectly. There's still something going on. But then if I saw some Doppler signals, I might need to investigate further what's going on. Maybe it's a tricuspid valve. Say we're doing some blind Doppler, the PDOF transducer. If we see something like that, then we need to go back and try to investigate what's actually causing it. Or I showed an image the other day where we had a big mass that was, going in and out of the mitral valve. That was what was a myxoma. So it's a big mass that's attached inside the atria, usually to the atrial wall, and it's protruding in and through the mitral valve, and that would cause a big spike in velocity. Now, if it was that, I would hopefully, if we were looking at the mitral valve, seeing it opening and closing good, hopefully we noticed that big mass that was protruding into it and blocking the hole as it was trying to pass through. So those are just sort of the common sense things as we get into this that I want you to think about as we go through, just like the other valves. Okay, so let's jump into the PowerPoint. So good. So general concept, 2D, we want to see it. We want to do some things in M mode. We want to do some things in color Doppler. We want to do some things with spectral Doppler as well, both pulsed wave and continuous wave. How do we, so we have a way to describe to the doctor. So first of all, if we see the valve not moving correctly, how's the first way you're going to describe it based off our early images?
Restricted.
Okay, yeah, you could comment that you think it's stenotic, you think it's restricted, you might have thickened leaflets, you might have calcifications attached to it, you might have, you know, thickening in certain areas. For example, at the tips is going to be more prominent with rheumatic mitral valve disease, rheumatic stenosis, which is the most common form of mitral stenosis worldwide. But in the U.S., it's not prominent because we have good medicine and we have antibiotics and things that can help tame these issues before they become problematic to the valve. But in third world countries, mitral stenosis due to rheumatic disease is very common. But it has a classic thickening at the tips only, and then it progresses down towards the annulus. Whereas other mitral stenosis, the one that's more common in the US, is mitral annular calcification. It starts at the annulus and works its way towards the valve leaflets. So depending on where you see the burden of thickening and calcification, could depend on what type of stenosis it is. Nancy, you had a comment?
Where was the on the tips from the rheumatic? Is that the hockey puck?
That's the hockey stick appearance.
Stick.
Yep.
Yeah.
Yep. The puck might be more like the myxoma floating through the valve. I'm going to say that, but yeah, hockey stick appearance is definitely the description there. Good. So again, let's just get into the basics of it. Oh, and my other point too is, so we go through, we quantify, we tell the doctor what we see, but anything in good science is quantified with actual measurements. So expect to be doing a lot of measurements in 2D and Doppler, and just representing that as best you can. Once again, if we're screening for something, it's okay to do one sample. Like we typically do one sample of the mitral valve tips. If we get into a pathologic situation, then we're going to start taking a minimum of 3 measurements. So if I've got a mitral stenosis with a regular heart rate, we will always take 3 measurements so you have good mathematic accuracy. And then in addition to that, if we have an irregular beat like atrial fibrillation, then we need to take a minimum of 5 consecutive beats each time we see the valve. So it dramatically increases the number of measurements you're going to take, but those measurements are meant to get better mathematical data. So going to the valve apparatus. So aortic valve and pulmonary valve, semilunar valves, they are very basic in setup. They don't have extra things attaching to them. They simply have those cup-shaped leaflets. There's 3 of them on each. They're roughly the same size. So what do you know about the mitral valve at this point that you can tell me about its structure? Nancy?
Are you sharing your screen? Sorry to interrupt.
Oh, sorry, I guess not.
But
it makes you
it's 2 leaflets.
2 leaflets, yes. So I know that many of you have come from, sorry, I'm just double thinking as I'm trying to do this here at the same time, which explains why I wasn't seeing it the way I was thinking I was going to see it. So you guys came in from usually AM
Scallops.
describing it as bicuspid aortic valve. So yes, it is a bicuspid. In the cardiac world, we do call it the mitral valve. Okay, so good. So we have 2 leaflets. What do you already know about those leaflets? Are they just simple 2 leaflets? So they each have 3 what? Scallops.
Scallops.
Yeah, we like to relate things to food. I'm kidding. I don't know if that has any relation to food, but it makes me think of food. So we have 3 scallops per leaflet. It is important as echotext that we identify these. So remember when we label them from that short axis perspective, which is coming up on another slide here in a minute, we start from the lateral aspect and label them A1, 2, 3 and P1, 2, 3 for anterior and posterior 1, 2, 3 scallops. And so we describe defects in the valve when they're going to do surgical procedures on them. We need to define what area, which scallops are involved in that process so the surgeon will know how to plan the surgery. Good, so 2 leaflets, 3 scallops each, anterior and posterior. which leaflet is bigger, has more valvular tissue, and which one is longer? Okay, so anterior is the bigger, more redundant leaflet. It's the one that we see most often. The posterior leaflet is short, but it wraps around quite lengthfully around the outside. Part of that mitral valve structure is the annulus, just like all the valves. So we have an attaching point of the valve leaflets to the base of the heart where the valves all attach. Then we have, so this is different than the semilunar valves. We have now the chordae tendineae. So the chordae tendineae and the papillary muscles and even the LV wall to some degree are considered part of the mitral valve apparatus. So when we're talking about the mitral valve, it's not just the leaflets, it's not just the annulus, it's also the chordae tendineae, also the papillary muscles, and even the left ventricular wall, because if they become affected, they significantly affect how that valve can function. And then what is the zona coapta again? So that's the area where it actually closes together. So that's the zone of closure, essentially. So that should be pretty familiar at this point. Okay, so here's again that short axis view. I do want you to know the differences between a transthoracic view, which is our standard echo views that we take, the transesophageal perspective, which is basically up, down, inverted, and then the surgical perspective, which is left, right, inverted compared to our transthoracic view. So we've gone over this already, but just being aware of that and then knowing where your aortic valve sits in relation to that and using your other landmarks like the left atrial appendage is important. Okay, that helps you to determine what's anterior, what's lateral, etc. And then just other concepts we want to cover here briefly with the valve itself. So a normal valve, we know, comes from the annulus, it kind of wraps in. We have our area of closure. We want it to go like this. We want a good zona coapta. We don't want it to tent, okay? We don't want it to pull apart. We don't want it to prolapse where it slips back, and we certainly don't want it to flail so that the leaflet tips are pointing the wrong direction. Along with that, you might have thinning of valves, you might have scarring of valves, you might have calcifications on the valves, a myxomatous process, which is an overall generalized thickening of the valve. And then we can even get into things like perforations where that patient may have had an infection, for example, that created a hole after that infection because of the weakening of the walls and the tissue that was going on there. So those are all things that can affect the valve overall. So in stenosis, we're going to see not a lot of change in that diagram. That's going to be more applicable to regurgitation. But again, this is just a preface to all valvular disease of the mitral valve. Okay, so in mitral stenosis, again, main thing is we've already defined, I think Mike defined it well for us, is really, it's a narrowing of the valve. It's a, so the take-home message when we're trying to do our quantification and what we're trying to tell the doctor is, number one, that it's not opening correctly, but what does the doctor want to know? They want to know the size of the hole when the valve is fully open. So how big is the opening left over when the valve opens? Okay, so when we attempt to quantify this and to show it by imagery, we want to be able to prove the size of that hole. That's our goal. Okay, again, just to go over etiology. So starting again with rheumatic fever. So again, worldwide, I was just reading again in ASC's book this morning. Worldwide, the rheumatic fever or rheumatic stenosis is the #1 cause of mitral stenosis worldwide. Again, in the U.S., because of modern medicine and good care, it's not really an issue in the United States as much. Having said that, do not be surprised if we start to get more drug-resistant strains of these types of bacterias where we may not have as many drugs or any drugs in some cases to combat the bacteria and stuff that are causing it. So with that progression into the medical world, now we may start to see some of these diseases that we thought were gone away in the US are now coming back with a vengeance. Okay, so you may start to see some of these things again in your lifetime. Okay, just be aware of that. Okay, so some patients may have rheumatic fever. Some it's a congenital thing. So again, what is the difference between like a rheumatic fever, for example, and congenital?
Congenital is something that you have at birth or develop during fetal development.
Yes, exactly. And is that always a genetic cause?
No, not always.
Does not have to be genetic, but can it be genetic? Yes.
Yes.
So do make that distinction because things can happen on a one-off that just developmentally happened during that developmental process, and that is a congenital type of malformation. Severe annular calcification or severe MAC. So where else did we talk about MAC already?
With Sam?
Not with Sam.
Hokum? No, those are good together. What's
So what
Is it diastolic
Think-
dysfunction?
say that again, Yesenia?
Diastolic dysfunction?
Not dysfunction. So think of when we talked about organ systems, it can be affected by a certain organ system.
Oh,
Kidneys.
Renal disease, yes. So chronic renal disease, stuff like that can affect the blood calcium. Also the parathyroid glands too, if they're overproductive to depositing extra calcium into the blood, that also puts you at higher risk. So it doesn't just have to be renal disease, but it certainly can be in those patients. So that's where we've talked about MAC before. So MAC, typically you'll see it in parasternal long axis view on the posterior leaflet annulus. That's where we typically see it first. But that again starts at the annulus and progresses towards the tips. Okay, whereas rheumatic fever starts at the tips and works its way back. So you'll see that restriction initially at the tips. You'll see that hockey stick appearance motion of it. Mike, go ahead.
Did you say that was renal disease and what else was the other one?
So parathyroid can also affect blood calcium. So if the parathyroid glands sit on there's four of them, they sit on the backside, the posterior aspect of your thyroid lobes. They affect blood calcium. So people, for example, that have like osteopenia and osteoporosis and stuff like that, they may have parathyroid, for example, affecting that. But it can also affect the heart. Okay. Good. Left atrial tumor is one etiology. So I already showed you a picture of that where we had that myxoma. And there, again, we're going to talk about masses in a later chapter. But a tumor may be protruding into the hole of the mitral valve as it's trying to open during diastole and plugging that hole. Okay, so you might see some dynamic changes with that because of a mass or a tumor protruding into it. Left atrial ball valve thrombus. So a ball valve is a specific type of valve transplant. So we're going to talk about valve prostheses after this chapter is done. So on Thursday, we'll start to talk about that. But a ball valve is a type of valve that actually has like a ball. If you've ever played marbles and you've seen those little steelies, it looks like a big steel ball and it's in a cage. And it bounces back and forth, just opening and closing that orifice when they do a valve replacement. That's an old style of a mechanical valve, but that ball valve and other valves as well can cause red blood cell destruction. And when we cause red blood cell destruction, what happens to our blood?
gets thinner?
Okay, well, it ruptures the cells, but if I rupture a cell, what does that trigger to occur?
Clot.
It triggers a
Clotting.
cascade of clotting.
Cascade.
Yeah, so if we're damaging cells, that triggers out little releases of chemicals and hormones and stuff that cause the clotting factors to trigger, and then we develop clot. So that's where that ball valve thrombosis may come in. So if that becomes stenotic, that can cause a mitral stenosis as well because it sticks the valve in a closed or partially closed position potentially. Okay, infective endocarditis. So again, that may damage. So this is going along with that rheumatic fever, but there are other infectious processes that can damage your endocarditis and the valve lining as well. So similar type of process. We're essentially scarring up the valve to where, it may fuse with other leaflets, or it may just restrict that motion just because of the inflammation process. Malignant carcinoid. So we talked about carcinoid before too, right? What does carcinoid name make you think about?
Metabolites.
Okay,
Right
metabolite
heart.
specifically, yes, right heart. I think that was Ella that said that. So yeah, those right heart are affected. Can it affect the left heart? We're talking about mitral valves, so
If there's a shunt.
if there's a shunt, exactly. Good. Systemic lupus erythematosus, which is an autoimmune disease. Rheumatoid arthritis, polysaccharidosis, mucopolysaccharidosis. Saccharidosis. I can't speak today, sorry. And then this methsergide, I can't pronounce that either. So that is used as a migraine medicine, okay? And sometimes when we're using these other medications, they do affect things. So what that does then is usually it's used for the migraines, but it can affect the heart. It affects it causes a fibrosis essentially of tissue, not just heart tissue, but the heart valves can be some of the tissue that becomes affected by that migraine type of medication. The Batista procedure, which is a surgical procedure, and then iatrogenic causes where they don't really have a well-known cause of that. I think those types of things are becoming less common because now we're starting to identify what does cause these weird things to happen. I did put it, I like to put again the little comics and stuff on here, but this is acute rheumatic fever. So again, not just looking at the heart. And as you're building your portfolios, I would encourage you to go and maybe explore a little bit about other body systems. And, you know, when I'm talking about rheumatic fever, what else does it affect? Is it just the heart or is it other things as well? So this little diagram kind of shows you that you can have vegetation. So we will talk about vegetations with our masses, and we've already discussed them a little bit so far. But that's basically a growth of usually bacteria or fungus on the heart valve itself caused by this inflammation process. Or it allows a nidus of infection to seed into that tissue and to start to grow. Okay, remember that those vegetations are typically on the upstream side of a valve, of any valve that it forms on, but doesn't have to be in that location. It can attach in any other location it wants, but that's most common. So with valvulitis, you're going to have a whoosh, swish, gurgle, etc. So in other words, there are sounds that become evident with valvulitis. Pericardial rub, okay, where the pericardium is actually rubbing as the heart beats, it's rubbing on those various surfaces. Erythema marginatum subcutaneous nodules. So pathologically, if they're to look, they'd see these. You're probably not going to see them on echo. Patients might have arthritis or arthralgia, among other things. So that's just a little synopsis systemically what a patient might present with. Okay, the history. So dyspnea on exertion. So have we ever heard patient coming in with dyspnea on exertion with cardiac stuff before? Yeah, super common.
I'm shocked. I've never heard about that before.
Yeah, and what are you going to treat them with if they have that? Oxygen, right? So
A pillow.
oxygen in a pillow sounds good to me. So yeah, I mean, some of these things are going to be very broad things, just that they're systemic ways that the body handles or they express its stress in various ways. So it just tends to have a broad way to do that. But again, what we're trying to do is to determine the things that are more specific to stenosis in this case. So hemoptysis is one of those. Hemoptysis, what is that? So hemo is
Blood.
blood, good. And the ptysis?
Kind of like a cough. Blood.
Your blood. Okay. So these patients, so again, I like you to try to think of, you know, why might the patient be coughing out blood if they have mitral stenosis? What does mitral stenosis do that might cause that to happen? What do you think? The
Pulmonary.
job of the mitral valve is to let blood through from the atria to the ventricle, right? And the real job is to prevent backflow. Okay, but if we're in an open situation during diastole, we're trying to get blood from the atria into the ventricle. So if that's being significantly restricted, what's happening to the blood and what's happening to the pressure and where is it going?
Is it backing up into the lungs?
Yes, it is. And the lungs are right there, and we're putting high pressure in the vasculature of the lungs. If we put enough pressure on the lungs, guess what happens? Some of that blood actually leaks into the lung itself, into the alveoli, and the patient will be coughing it up, and they're going to be getting fluid and stuff building up on the lungs. Beyond the lungs, what else does it affect, you think? So from the lungs, what comes before the lungs?
The
right
pulmonary
heart.
arteries and the right heart.
The arteries, and then,
The liver.
well, first the right ventricle, right atria, liver. Yes. So it backs up all the way through the system, right? So we're getting that hemoptysis, and then it's going to eventually, it's going to restrict what the right ventricle can do. Therefore, we're going to get a backup, and you'll notice the bottom one there, they potentially have right heart failure. So these types of things contribute to that entire process. So again, these are usually very chronic, long-term processes that happen, and it's a gradual buildup through the entire system. And yes, it can certainly affect the liver also with a cardiac cirrhosis type of presentation. Good. Palpitations, chest pain. Again, why do you think we're getting palpitations with a stenotic valve that's just not opening properly?
It's
Pressure.
electrical system.
Yeah, so the pressure builds up, it stretches the left atria. Stretching tissue is going to affect your electrical conduction potentially, but also if you've got jets and things like that too, we know that they can also physically hit the tissue that has the electrical signals behind it, or the conductive cells, and can start triggering these abnormal irritant type of rhythms. And therefore, we get into the one that concerns us most usually from this perspective is the atrial fibrillation. Okay, so as we stretch the left atria, we get into left atrial fibrillation quite often. And what are we concerned about typically when we see that?
A clot in the atria.
Yeah, so we worry about clot, particularly left atrial appendage. Now we can get, because those signals are going from the left atria, they also can go to the right atria. Again, just as a reminder, where does clot typically form in the right atria? It is not the right atria.
It's at the muscle. It's at the muscle there.
Yes, that pectinate
That's
muscle
called something.
the end
Yeah.
muscle on the anterior wall. Good, just as a
I
refresher.
learned a new fact, so that fact left.
All right, orthopnea and paroxysmal nocturnal dyspnea. Let's break that word apart. What does that mean, or that phrase?
At nighttime.
Time,
It's
good.
hard to breathe at nighttime.
So dyspnea we know is hard to breathe. Yeah, so paroxysmal, so they're laying down. So it's typically when they lie down at night, and this is typically because of that backup of fluid and pressure in the lungs. They start to collect fluid and stuff in the lungs, and the patient can't sleep, and it's relieved by sitting up. Okay, so sometimes the importance on your diagnosis can be found in asking the patient what makes the pain go away, or what makes your symptoms go away. And if you find that they're laying down and that's when it happens and they sit up and they're good, that might help to narrow your diagnosis to what's going on. Fatigue and syncope. So syncope is what? So fainting. Good. So again, and when we talked about fainting with like the aortic valve stenosis and regurgitation, what process do you think is going on that's causing a patient to faint potentially?
Is it the lack of blood to the oxygen through systemic?
Yes, so we're just not getting it. So just like the aortic stenosis, it's just a little earlier in the game. The mitral valve is not opening enough. It's not letting enough blood flow. Now we're talking against severe cases in this case, not mild, but we're not getting enough blood up to the brain, and that can certainly cause that. Good. Physical exam. Yeah, go ahead, Mike.
Would you see the hematosis or how did you say that one? Ugh.
Hemoptysis. I don't know if that's how
Hemoptysis
you say it.
and right heart failure. Would you see those only in like severe cases as well?
Yeah. Yes.
Okay, I thought as much,
You're not
but
gonna,
just
you're
want to
not
make
gonna
sure.
see it, you're not gonna see it typically in mild. That's true. So most of these bigger symptoms are certainly going to be of the severe to critical nature. Good. So in the physical exam, they might notice that the blood pressure is low normal. So it might still be within normal range, but it's low. Okay. To know that for that patient, they would have to be doing serial studies over years, probably, and having some good baseline studies to compare that to. Irregular pulse. What does that phrase suggest to your mind automatically?
AFib.
AFib. Yep. Think back to EKG. That's the one that's irregular pulse. Just there's no rhyme or rhythm to it. It's not a cyclical abnormality or cyclical abnormality. It's just random. Okay. Malar flush. What is malar flush? Anybody know? This is where Google's handy. So it is a plum red discoloration of the cheeks. Okay, classically associated with mitral stenosis due to the resulting CO2 retention and its vasodilatory effects. Okay, it can also be associated with other things. So that's what malar flush is. You got your patient with red cheeks coughing up blood. Okay. You might have a small or absent LV impulse. Okay, so now we're talking about palpating the PMI, the point of maximal intensity on that left ventricular apex, trying to feel the beat, right? So it might be small or weak, and or you just don't feel it at all. Okay. What do you think is happening there? So usually with aortic regurgitation, we said it was pretty intense because we're getting extra volume back and the heart's really trying to squeeze and really push it. So we get a big impulse. Remember, we get those heaves. Same thing with stenosis. We're pushing against the restriction and we're trying to really force that blood out, and we never get all of it completely out. So we have that extra volume preloaded there as well. But in a mitral stenosis situation, we're not getting enough blood into the LV. So what do you think the LV size might be like?
The same.
Okay, good. Yeah, so the LV size will be the same or smaller than normal. Okay, because we're just not getting the blood into it. Remember that the LA, the LV, or the RV, LA, RV, and RA might all be large, but the LV will be preserved or small. Okay, paranormal right ventricular heave. So again, we're now starting to feel it on your right parasternal perspective, and this is again physical exam, so just palpating it. We know that we potentially have right heart failure. We have at least a buildup of pressure and volume into the right heart. So again, the right heart is working extra hard now. The left heart doesn't have to work as hard because it's not being filled as much. And so Starling's law of the heart, remember, the more you fill it, the more it's going to have a forceful contraction and so forth until it passes that threshold where it kind of gives up. We might have an apical diastolic thrill. So this suggests that we're listening to it with a stethoscope and we can hear that sound going on. So again, in a stenosis, do you think there's any turbulence? Yeah, definitely. So any stenosis, there's definitely turbulence. Any regurgitation, there's turbulence. So the key here is thinking, okay, what part of the cycle am I hearing this? Is this in diastole or is it in systole? So mitral stenosis is occurring at what cardiac cycle?
Diastole.
In diastole, correct. Yeah, so you're kind of pointing towards that valve. Remember that you're sitting over the left side here with your stethoscope. That's where you're more likely to hear the mitral valve because you're closer to that valve and its flow direction. Whereas, kind of by the xiphoid, you're going to hear more of the tricuspid valve. Remember up here, because of the direction of pulmonary, you're actually going to hear the pulmonary on the left side of the sternum, and on the right side of the sternum, you're more likely to hear the aortic valve, just as a refresher. Okay, and then we have what's called Ortner syndrome, which is a hoarseness. So going along with that whole lung issue and stuff like that, they might have a hoarse sounding voice and some coughing. Okay, so what problems can mitral regurgitation or can mitral stenosis cause? Okay, so one of the things that we often find in any valvular stenosis is that because the valve leaflets are typically thickened or there's something malformed about them, it's not opening quite right. But because of that malformation, it also tends to not close very tightly as well, allowing at least a minor amount of a leak. So in this case, we might see some mitral regurgitation along with mitral stenosis, and that's not an abnormal thing to see. So in most stenosis situations, I would expect to also see at least a little bit of MR or regurgitation on whatever valve you're looking at. But if it's a leaky valve, depending on what's causing the leak, I may not expect to see a stenosis. Okay. There could be a passive or reactive pulmonary hypertension. So again, it doesn't surprise us. We got that backed up of pressure and stuff in the lungs. We might see some left atrial thrombus, again, because of possibly that stretched chamber, maybe atrial fibrillation, etc. Systemic embolization. So if that thrombus breaks off, obviously that's problematic. Infective endocarditis might be the process. Pulmonary edema, hemorrhage, embolism, and/or infarction. We could have decreased cardiac output. So they've got right heart failure. How's that going to affect our cardiac output? Remember, right heart failure is usually because the right heart, we have a low ejection fraction because the heart muscle is just kind of given up to some degree. So we don't have a good production to the lungs. Does that mean that the left heart's not going to work as well either?
Yes.
Not necessarily. It might, but it doesn't have to. The right heart can be weak and the left heart can be perfectly fine. So it all kind of depends on what's happening. But if I've got if I've got the decreased cardiac output, we're suggesting that that's going systemically. Why do you think a mitral stenosis would cause decreased cardiac output? And does that have to be because of heart failure, or can it be because there's just not enough volume?
I would assume it's just because of the volume and of starlings.
Yes, correct. So it's because we're not getting it filled up initially. Could the heart be failing? Yeah, that's potential as well. That's probably more of a long-term effect. But it's more likely because of that lack of volume, that lack of preload, and that starling's law of the heart concept. Good, auscultation. So this is the sounds that we hear with the stethoscope. So going back to the stethoscope, what heart sounds do we hear typically on a normal individual?
Lub dub.
Lub dub.
Yes.
Yep. And we label those as S1, S2, meaning sound 1, sound 2. Okay. If remember that we hear the lub down lower better, and we hear the dub louder when we're oscillating up higher on the chest. So which one is associated with which? Which types of valves? So we have atrioventricular valves and we have your semilunar valves. Which one is giving us the lub? Which one is giving us the dub?
It says it on there, but
The mitral valve
Mitral
is
S1.
yeah, S1.
Sometimes all we got to do is read, right? Good. Yes. The atrioventricular valves are the lub or the S1 sound, and the dub is the S2 sound. So those are combination ones. That's typically because those are happening very close to each other, and we usually can't perceive the difference with our ears. So sometimes when things become abnormal, we actually split out the sound and you can start to hear things distinctly different. So in here, we're going to talk about the A2 and the P2. That's actually hearing distinctly the aortic valve shut separately from the pulmonary valve, which is P2. So if you're seeing like an A2, P2 split, that's what we're talking about. The sound is separated out enough that now I can distinguish them with my ear. Okay, but normal patients, you're not going to really appreciate the difference between them. Okay, so we do hear an opening snap with this. So normally speaking, the S1 sound, what creates the S1 sound on the atrioventricular valve? What are we actually hearing?
The closure.
Yeah, we hear the closure. That's our lub. Okay, If the valve opens and it flails open widely and it's just doing this, am I going to hear that? Okay, what happens when you deploy a parachute? Do you hear the sound when it opens and catches the air? Okay, so that's what's happening with the mitral valve. And you can think of mitral valve stenosis that way. You've got the flow coming up under it, and poof, it comes open, but it doesn't flail open. It gets stuck, and often there's some little holes in those parachutes that let air through, but overall you hear that snap. And so we can hear that opening snap when that occurs. And that also gives you the perception of the doming too. So if you're seeing a dome-shaped valve in long axis of the valve, that's an indication that you have a stenosis. You want to normally see the tips of the leaflets open so that it's straight open. Okay, so here's a couple new terms. So we have crescendo, pre-systolic accentuation of the diastolic rumble. Blah, 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 what does that mean? In music, a crescendo is what? Getting louder. Decrescendo is getting quieter. Okay, so keep those terms in mind. So this is a crescendo, getting louder, pre-systolic, so it's at the end of diastole, before systole. It's an accentuated diastolic rumble. So when you're listening to this with the stethoscope, you're going to hear this kind of, and so that's the kind of sound that they hear. So if I know there's a document that I put on your reference material on the modules on Canvas. I don't know that that one had some audio to it. There might be another one there. I know that there was some with some audio, but it wouldn't hurt to YouTube some of these heart sounds to see what they actually sound like, because they'll give you some little audio clips of what they actually sound like so that you can appreciate what it is. And I would recommend having a stethoscope when you're in the cardiac world. If you start to see patients with certain of these disease processes, it's good for you to listen to it and see what that actually sounds like. You're not the one going to diagnose it, obviously. But I think it's helpful to have a stethoscope. So maybe you get that patient that's a new patient to the facility, and you can take your stethoscope prior to your exam and quickly listen to the various spots. And maybe you can detect some of these things, giving you another piece of the puzzle. Because when that patient comes in, especially from an outside facility, you're probably not going to have all this history. You're not going to have these oscillative stuff in the chart and stuff like that necessarily. So the more tools you can have, the better. Just keeping in mind, you're not the one diagnosing it with that. So I'll let you go through the various other heart sounds, but you have the narrowing of the S2 split, the accentuation of the P2, etc. Now you might also have a murmur of the mitral, aortic, tricuspid, and/or pulmonary regurgitation as well. So the point is, if I've got mitral stenosis, what do you think is possibly happening to the other valves? They're the same type of structure, so they're likely affected by the same types of things. Okay, so when I look at the other valve and one's really nasty looking, pay attention to your other valves, because more than likely they also have something going on with them too. Okay. Treatment, again, treat the cause. So whatever the cause is, or what we find is causing symptoms and stuff, we're going to treat those. So prophylaxis, antibiotic therapy, possibly. Things for endocarditis. Cardioversion might be a potential if they've got AFib or rhythm abnormalities of other kinds. Digitalis, beta blockers, calcium agonists and stuff like that, anti-arrhythmic medications. So again, they're really going to treat what symptoms are going on, and if they can find what the cause is, they're going to try to treat the cause. Again, continuing that, anticoagulations, diuretics, et cetera, et cetera. They might get to the point of actually doing balloon angioplasty. Back in the day, they'd go right into the valve, they'd balloon it open. We saw that 3D clip of that the other day, and it just, basically tears the native valve that's restricted. It tears it open. They may have to do more beyond that, or maybe that did enough for what they're looking for. They might do a commissurotomy, so they're actually cutting into the valve. So reopening the valve leaflets that have fused together, for example, suggesting it's along the commissure. Or they could be doing a valve replacement. Yeah, And there's other valve surgeries that will be done, but those are more for regurgitant type of processes.
Is that the ball valve?
Yeah, that's the ball-in cage. So as you can imagine, as flow comes in, let me grab my little pointer. So as the flow comes in, so this would be protruding out into the left ventricle. Okay, here's your little Steely type of ball. Now it's not like super heavy like a Steely, but it's got some weight to it. You can see this material around it. That material is a specialized type of material that's less likely to allow for clot to form on. So it's very smooth and slippery. But the flow is going to come in from underneath. It's going to come up through the valve, as you can imagine, pushing the ball up. When the ventricle squeezes, it pushes the ball back down and shuts it. But look at all the red blood cell damage that could potentially happen around the edge of that. Okay, so these do, when people have mechanical valve replacements, they have to be typically on blood thinners. All right, so let's go to our echo. So typically we will take 2D first, and I probably should just rearrange these slides, but regardless, what I see in M mode, I should see similar things in 2D. So these images at the top to start with, the one on the right is an inverted image. So the black and white is inverted compared to how we normally look at this. The right-sided image is how it used to be done until they inverted it. So nowadays everything's this way with the black fluid and the white for the tissue. All right, so we should see a thickening of the valve to start with. So notice how these are, so in this view, we're used to seeing that little mountain with taking our EPSS measurements on, and it's usually thin leaflets. You can see how thick these are. Okay, so you'll notice the thickening. The other thing is that you'll notice our mountains are gone. You'll notice that it's the opening is this little residual box right here. So the posterior leaflet is getting drug up with it because these are being tethered together. And the anterior mitral valve leaflet is the dominant valve because it's the bigger one. So that's what an M mode of a stenosis looks like. This is what it looks like with the picture inverted. So in this case, the white area is the opening of the valve itself. Okay. So noting the points of it. So do you remember the alphabetical labeling of the mitral valve in M mode? You have your A, B, C, D, E, and F. So remember, A is your A wave. B is only there if we have elevated left atrial pressure, and that's going to be that B bump just after the A wave. So start there and go clockwise around it. C is where the anterior mitral valve leaflets close together. And then we jump back to the other side where we have the D, which is the opening of the valve leaflets. That's the separation of the anterior and posterior leaflet.
Hey, Scott, could you draw that? It's been a minute.
It's been a minute. Yeah, let's grab me a little pen
Point
on
to them
there.
as you're discussing it or something.
What's that?
Or if you could use your pointer and point it out.
Oh,
Yeah,
look,
these are abnormal ones, so they're not going to see it. Let me.
I found it.
Okay, let me see if this isn't drawing it. Why is this not drawing it? I lost my little pen that I use on my drawing pad. I wonder if it will let me do it with my finger. All right, so everybody look at Nancy's screen. She's got it drawn out there. And if
Is
not,
it big enough?
Just go back and review that. I can see it. Can everybody else see that okay? Maybe.
Somehow I cannot see Nancy's picture.
Probably have to click on hers and then it'll open up bigger. That's what I did.
Yeah, so click on Nancy's picture.
So I don't have the B. When you said the B is only when? Oh, I have a question mark. B, it's right there.
Yeah, B is when we have elevated left atrial pressure. Let me do this. Let me try to bring up an image.
Oh, look, I have it there.
Yep. Let's do this. Good old Google. Images. See if we see if there's any labeled ones. Here we go. Good. So this one here, so we have the E over here, we have our A. The B isn't super prominent on this. They have it labeled. I guess this one over here, you can see a little bump right there after the A. That'd be a B bump. It gets more prominent as it becomes more defined. And then you have, I usually circle back on the same valve opening cycle. So I go A, B, C, and then jump back here for D, E, F. They just put it over here, continuation of it, but the valve's closed in between here. And then you're just looking like EF slope, for example, is just the slope between there. D to E excursion is just from the valve opening to the valve to the E, so where it starts to open to where it fully opens. D to E excursion may be something that is relevant to mitral stenosis specifically, because that tells us how wide that leaflet. Well, it's telling us the motion of that leaflet. It doesn't actually tell us how wide. The width is measuring in between the posterior and anterior leaflets. Let me do mitral valve stenosis. Okay, so you can see here, let me bring this one up because you can see it a little bit more clearly. This opening between the leaflets tells us how wide that's opening. So that's one way to measure the stenosis, the degree of stenosis. Okay, let me bring up a little bit more severe one. In this case, there's a lot of reverberation, so it might be hard to tell the exact opening and where the posterior leaflet is, but you can appreciate that there's some opening in between here. So that's a more narrow one there. This one has a pretty narrow opening between it there. Okay, so you get the idea. So we lose our M shape, our mountain shapes, and we get that more boxy shape dragging up that leaflet with it. The leaflets are typically thickened. There's usually a lot of reverberation that's associated with that, etc. Good. Jump back to here then. So the anterior motion of the posterior mitral valve leaflet is because it's tethered to the anterior, so that's drug up instead of reflecting opposite of what the valve with the anterior leaflet usually does. Decreased A wave of the mitral valve leaflet. Reduced mitral valve leaflet excursion, so it doesn't travel quite as far. Again, because they're tethered together. The AC slope, if you're to measure that, is steeper. There's a decrease in diastolic separation between the leaflets, which I showed you just the difference between the distance between the posterior and anterior. Pseudo pansystolic mitral valve prolapse. Okay. Now that doesn't, let's see. Oh, so it looks like prolapse, but it's actually not prolapse. Prolapse is going to be seen when valve is supposed to be closed. There could be left atrial dilations. Remember, when we're at the aortic valve level and the aortic root and measuring the LA, we might see that the LA is dilated. So that's one thing you would see on M mode. But that measurement is a secondary piece of information to the valve itself. Anything that we see the valve itself is primary information. Anything that's looking at a chamber that's even adjacent to it is a secondary piece of information.
Scott, what does it mean, pansystolic?
Pansystolic means that it goes all the way across systole. So pansystolic or holosystolic indicate that that event happens all the way across that cycle.
Okay, thank you.
Good. Okay, so the right ventricular hypertrophy or dilation will also be noted. Again, that's a secondary feature. You might have what's called the early exaggerated diastolic septal dip of the interventricular septum. And that's because the right heart, remember you got the big backup of fluid and stuff in the right heart, that's causing that to happen. So that's again a secondary sign of this. You might have abnormal septal wall motion that could be paradoxical. So paradoxical means that it's doing opposite of what you expect it to do. So if it's supposed to be coming down, it would actually be going up during that time. Or it could be flat. What do you think could cause a flat septum? in M mode?
Dilated left ventricle.
Not necessarily the dilated left ventricle. So we got to, so remember mitral stenosis, the left ventricle is going to be the same size or smaller, but the right ventricle is going to be big. What happens when we get a backup of volume and pressure in the right heart? What does that do to the septum?
It pushes back.
Yeah, so it pushes it down. So that causes the flattening to occur of the septum. So with the M mode, again, I'm just going to reiterate this. I'm not going to go into super detail on my testing, but I do want you to know the information because for registry, M mode is still testable. We'll say that. You will find in most labs that most of the stuff on here for like the A to C slope, for example, D to E excursions aren't really something that's measured anymore. But it could end up on the registry. So I do feel that it's important that you know that. And there are some older techs out there that still do a lot of these things as well. Those ones are typically going to be retiring soon, giving us jobs available, right?
So don't know that page, know that page.
So I do want you to, for my test, I want you to know just some of the basics, like, you know, what you would expect to see on the valve thickening, you know, the fact that the posterior leaflet's tethered to the anterior leaflet. It's more of a box shape when it's open, and really that's the part we're interested in. As far as measuring the points, E to A and D to E and the different slopes like that, I don't really care that much about, to be honest. But do stick them in the back of your mind, or at least in your portfolio, so that when you're studying for a registry, that you don't totally forget those items, because they could come up. Okay, so generally speaking, those are the things we saw in M mode. You're likely to see the same things, but in a 2D version of it. So in the 2D version, we're going to see thickened leaflets, but we're actually going to see the leaflets more distinctly. Note where the thickening is occurring. Again, is it happening at the tips or is it happening at the annulus? Is the calcification in which location is that in? You're going to notice the size of the chambers, like the dilated atria. You might see again the preserved size of the LV, and or it looks small compared to the rest of it. And you'll notice that in particular with the 4-chamber heart, because we're comparing those 4 chambers, ideally all similarly opened at the same time, or roughly the same time. Again, note the diastolic doming when you have it. So again, that's the leaflets can't let their tips come all the way out. They're restricted, so that it domes. That's always kind of a sign of stenosis.
Hey Scott, I was getting
yeah,
a
hold
little
on.
bit of like a doming, but that was due to like my angulation, I think, on my patient. So how would, at what area do we normally get that, and how can we correct that kind of like artifact?
So that's a great question. So if I see that, what do I do about it? Is it because it's an artifact, or is it because of something else? It could be artifactual. So you want to change your window a little bit. This is also why we look at it in 4-chamber. We're going to look at it in 2-chamber, long axis, etc. If in fact it's there and it's real, what do you think you'd expect to see with spectral Doppler? If it really is a stenosis, what is my spectral Doppler going to do?
I would expect to see like higher velocities and EA wave ratio being changed a little bit.
Yeah, so look for your velocity change. So if you're seeing something in 2D and you're not sure if it's real or not, you're going to use your other pieces of information to contribute to that diagnosis. So in the Doppler, if it comes out totally normal, or my other views it comes out normal, then it's likely that it was just a positional thing, which certainly could be. So you want to note it and just keep track of it and see if everything else supports that information. And that's the essence of what we're doing with our diagnosis. So remember the rest of the mitral valve apparatus. So the leaflets may be thickened, but also your chordae tendineae might be thickened. Okay, so you might be looking for chordae tendineae that look thick and shorter than normal, and they might be affecting that as well. You might have fusion of the actual commissures. So when you're in short axis for the fish mouth, maybe part of it seems like it's kind of fused together and you just have half of it kind of opening. You may even see somebody who's had a severe mitral regurgitation in the past has had a surgery where they actually surgically tie it together or sew it, the leaflets together in the middle, and or put a clip on, like a mitral valve clip, and it actually has two orifices that open and close, but the middle is tied. So you might see that. That's kind of a man-made, but sometimes we can cause stenosis because of that, because we make the holes too small, trying to reduce the amount of regurgitation that's occurring. We'll talk about that more tomorrow. Again, chamber dilation, spontaneous contrast we want to watch for in the left atrium in particular, and the left atrial appendage, making sure that there's not thrombosis likely and or thrombosis there. Pulmonary hypertension. How do we see pulmonary hypertension on echo?
PI.
Okay, so yeah, take your PI jets. You can also do your RVSP. So take your TR jet and you add the right atrial pressure to that. So those can give us ideas of what the pulmonary pressures are. Obviously looking for right ventricular hypertrophy and dilation as well, because that's long-term is going to back it up. All right, so here's your hockey stick. There's a hockey stick appearance of that mitral valve. So that mitral valve is fully open. So remember the aortic valve that I showed you guys the other day? They kind of curled in at the end, okay? And what will happen is that typically it will kind of have a pivot point here on this, and it'll have that hockey stick appearance when it's opening. Okay, so back to right atrial dilation, etc. These things should not be too surprising. Determine whether Lutenbacher syndrome is present. So that is mitral stenosis with an osteosecundum ASD. Okay, so now I got to pay attention to, is there a hole between the atria? And how are we going to see that? So if I see the ASDs, we're going to see them best from subcostal views, kind of perpendicular to those walls. So just be paying attention. So if we've got some stenosis, pay attention to the, especially if it's a congenital type on a young patient, you might pay particular attention to looking for ASDs and things like that. And then just like all other valves, if I've got stenosis on one valve, there's a good, decent chance I've got stenosis on the other ones too. So I'm also going to interrogate those valves as well and do what's necessary for those. Okay, and then planimetry. So planimetry, as I've mentioned, is not like the best measurement. It can be hard to get the right plane to get it exactly. If you have 3D available, the 3D can be quite good actually, because you can actually see the entire valve orifice, whereas taking a 2D slice, you're just taking a single slice through it, and you can way overestimate that hole if you're not coming in at exactly the right plane. Having said that, I'm going to read you a statement of the ASE book when it comes to quantification of the valve. When we're looking at stenosis, we're typically going to do a mitral valve area based off pressure half time, and we'll get to that in a second. But
What page are you on?
This is page 464. This is again out of the ASE book, so you may or may not have that. I just want to read you the statement because this is kind of the new standard. So if you have mitral valve stenosis, it recommends that the mean diastolic gradient and mitral valve area are determined by planimetry. So it does want planimetry. It recommends it on
dilatation.
And pressure half time be performed on all patients with mitral stenosis. So just like the aortic valve, when we do continuity equation, we also always have to take our PDOF transducer and find the highest velocity on the right parasternal border. On the mitral valve, they recommend that we always do a planimetry and pressure half time. Okay, so I just want to point that out. So when you're in a clinical lab, planimetry is not great in 2D. It's way better in 3D, but it sounds like now they want that to be a standard. Okay.
Are we supposed to push for that? If a lab
not,
doesn't do it?
I would not push for it. I would, you could suggest it like, hey, yeah, you know, we read in ASC, their recommendation is this. I would not push that in the lab. Those kind of things can really upset lab people. And we definitely don't want to upset them. They're giving us our training and stuff. It's very easy for us because we're into the book knowledge. We get a lot of tedious information that they either simply forget or it's a new thing that they just haven't come across yet. And we can introduce ideas, but just leave it at that. If they want to introduce it themselves, they can. Maybe you give them the document that you got that source from is good. I have had labs that have changed their protocols based on what students have introduced to them. But we have to be very tactful in how we introduce those concepts and making it so that we don't insult them and and upset them.
Right. I wasn't expecting to, as a student, like, hello, my status, non-existent. But when we are in the field, is that something we need to be advocating for? I guess I don't know.
Yeah, it's a good thing. So the way you advocate for that is actually to go to the doctors that that are in charge of that. So it depends on the size of your lab. I'll take inland imaging as an example. When we have a policy change in inland imaging, it's usually tied to some kind of a new research or a journal article or something that's been proven by the societies or maybe a multi-study type of thing. We bring that to our board. There's a physician that's the head of that. And as a group, we make up a decision, sometimes using technologists and sometimes it's just doctors. But ultimately, they will make up a decision as a lab. And if they want to use those exact numbers for thresholds or if they want to adjust their numbers, they're free to do that. So if we have these suggestions, we can bring the data to them and say, hey, this is the recommendation currently. Take it as it is. They can take it from there, bring it up to those meetings where they discuss those things, and then they implement it as a system. That's the best way to do is to bring it to the doctors that are really the ones in charge. If you bring it to individual doctors, you're going to be doing 25 different protocols, and that's no fun. Kelsey, you had a comment? Yeah.
I'm gonna retract my comment.
Okay. Bring it back up when you remember. Okay, so 3D, again, 3D is a great way to do your mitral valve area with planimetry. Again, because we can see the whole surface of that valve, you don't have the error-prone idea of taking a slice through at the wrong position. What you do have to watch out for in 3D is if you have your gains too low, you'll make it look like the hole is bigger than it is. And if you have them too high, you can overgain it and make the hole smaller than it really is. So you still have to be careful. You still have to make sure that other calcifications and stuff aren't shadowing out your view. And then our Doppler. So again, presumably with Tammy, you will be covering, if you haven't already, you'll be covering some of the mitral valve stenoses as well. I do have a few waveforms on here for you to see. She'll probably have some more for you to take a look at and talk more about the measurements exactly. But in the pulse wave and continuous flow, we're going to see, and I really should put color first. I have it at the end because it talks about PISA, and that's kind of a secondary piece of information. You can use it, but it's not as recommended as the other ones. But normally I would do color Doppler first. I would see some things on that. We're going to talk about that in a minute. So pulse waving CW, you'll see turbulent flow, first of all. So as we become stenotic and we're opening but restricting, so normally we just get a gush of flow comes through, but now that the flow has to conform, it forms almost a column of flow and then it comes into the chamber. You can see that confluence start to come together. You can see your reds starting to form together. The smaller and smaller it gets, you'll see the actual jet coming through the valve. Whereas on a normal valve, you don't really see a jet just because it simply dumps from one chamber to the other. Okay. Mitral valve E velocity at the valve tips is with pulse wave. In a stenotic situation, it starts to get higher than 1.3 meters per second. So if it starts to exceed, I usually go by like 1.5, like 1.4, I'd be like, maybe. 1.5 and higher, I'm always starting to think of stenosis. Then I'm starting to transition over to using CW for the highest velocity measurements and the tracing of it with the VTI, which will also give us our pressures. The decreased E to F slope or increased pressure half time. So where we normally take our decel time, we've already talked about measuring pressure half time. It's that same slope, but make sure that you're using the correct calculation tool, which has to be that pressure half time tool that you're using, because you won't get the same information if you're using the decel time. Yeah, Kelsey.
That was my question. So we were talking about this with Tammy yesterday. She said labs very rarely use, or maybe she's just not aware of adult labs using calculating the mitral valve area by the continuity equation, that it's mostly by pressure half time.
Yes, that is correct. So again, continuity equation is one way that you can do it. It's just another methodology. But again, the recommended from ASC is pressure half time, which is 220 divided by pressure half time. Okay, and so that's the information you need for that formula. And it looks like they're also recommending that planimetry, ideally in 3D if you can do it. So that's ASC's recommendation. But yes, you can do pressure half or the continuity equation. Yes, you can also do PISA. Those are perfectly acceptable ways of quantifying that whole. Nancy?
So when do, like, we talk about 3D and TEE, when we really learn about it, would that be in a job or in clinicals?
Probably in clinical first. That's where you'll actually get to see it used on a regular basis. Most 3D and echo is done in transesophageal. There will be some done with transthoracic, but that's few and far between, relatively speaking. But mostly it's TEE, and you're going to see that in the hospitals. We don't have a TEE transducer here to use, and it's a patient safety issue because we don't have medical staff and we don't have crash carts ready to go. So you can understand why we don't do it here, but yeah, you'll get exposure to that in the clinical sites, hopefully. On the job, at the very least, yes. Say you never got to see a TEE in your life and you got really good at doing echo, and then you get a job at a place, are they going to expect you to go in the room and do a TEE? They better not. I can't say they won't, because some hospital managers just throw you into whatever, but you should have somebody training you how to do it before they allow you to do it at their facility. So yes, you'll get the training that you need before you can do it. Good. Okay, so just go over these. So you got evaluation of the pulmonary venous flow. There's going to be a decrease in the S wave with a prolonged A duration and increased pressure half time of the D. Determine the pressure half time of the valve itself. So that's going to be done by CW Doppler. And again, we're going to do it just like we do the deceleration time. You're going to measure the peak of the E, and you're going to draw it along that line, that deceleration of that. And that gets extrapolated out to baseline. Again, if these are actual stenotic valves, you should be measuring a minimum of 3 consecutive beats on every one of them on a normal heart rate. Again, abnormal heart rate, always go to 5. So the mitral valve area, so on the aortic valve, I said that we report the AVA, which is your cross-sectional area of the aortic valve. In this case, we're reporting the MVA, the mitral valve area. Okay, and that's determined by the pressure half time, the 220 divided by pressure half time. It's also determined by the planimetry. It's also could be determined by a continuity equation and or PISA. Okay.
Did anyone else remember Tammy saying it was 220 minus pressure half time?
It's divided.
Yeah, I think she said minus.
She might have said minus, but it's divided.
Good to know. Change my note.
I think she said minus, but her PowerPoint actually said divided by, because I remember thinking the same thing. Yeah.
Oh, we do take 220 minus your age for our stress test, so I can see how I get confused. Now, she's also pediatric, so she doesn't do this measurement as much because she's not actually in an adult lab. This is a common adult lab measurement. Pediatric labs do less of these types of things. They do more tracking of actual connections and things like that with color Doppler. They do some Doppler, but this is common in an adult lab. Typically, mitral stenosis is an acquired process for older patients. Okay, and then determining our pressure gradient is simply taking your CW and tracing around it like a TVI. If you do a TVI over it, it's going to give you the numbers for your pressure gradient, for your max pressure gradient, your mean pressure gradient, etc., which is shown here. Okay, so that's the tracing of it. Again, get my laser pointer. So normal valve here, pulse wave, abnormal valve here. This is like a moderate stenosis. If you take the hash marks up here, so we got 1, 2, 3, 4, 5, 6, 7, 8. I doubt that's 8 meters per second, but it could be. That might be every other mark. So 1, 2, 3, 4. That's more likely 4 meters per second peak velocity ish. This one with a less steep slope is more severe. The ones with the ones that are more closer to normal, the steeper slope is going to be mild or moderate. The ones with a very gradual slope are going to be severe on mitral stenosis. So on this one in the bottom, just as a review, if I have atrial fibrillation, how's that wave going to look different?
It's missing the whoop.
Missing the whoop being the A wave. There you go. Yes, good. And your beat to beat is going to be erratic. And how many beats do you measure consecutively if that's the case?
5.
5.
5, good. All right, this is just a diagram of the basic measurements to take. So again, pressure half time is here. When you do this, again, you don't have to determine where the half time is. The system does that for you. It locks it on in that caliper. You just do the measurement and extrapolate it to baseline. Some systems you can just measure from here to here, and the system extrapolates it beyond automatically. Other systems will make you go right to baseline. You got you're still going to measure your peak of your E, peak of your A. You might do A duration, but if you do A duration, do it in pulse wave and bring it inside the annulus to see that more clearly, but that may not even be super relevant at that time. Nancy, go ahead.
So right now we're only CWing and PWing at the tips.
Correct. Yes. So CW is going to go right through the tips, but this is going to get all the velocities, including the highest. This is a screening tool using pulsed wave. Once we start to spike above it, we'll still do deceleration time off that. We'll still try to get a peak velocity, but it's likely going to go beyond what your pulse wave is capable of. And you might use it for A duration and those measurements here. But really, when it becomes stenotic, you're really going to transition over to CW. Kelsey?
Tammy said something yesterday about the mitral valve, like with a stenosis jet, that it will typically go towards the lateral wall. Is that correct?
That is correct. And not even stenotic, that's all jets, because the shape of the valve leaflets from 4-chamber view, the anterior leaflet goes more across the chamber, and you have very, like, we'll say that my annulus is here and the other annulus is there. So it's going to go more towards the lateral wall inherently. So it does that anyway on a normal heart. But yes, on stenosis, you would notice that as well. So the jet is actually directed towards the lateral wall, and then it wraps around and gets ejected. So there's a certain flow style that it actually usually takes. Good. And then tracing again just gives you all the rest of the numbers. It gives you your instantaneous peak velocities, adds them all up together. That's what gives your VTI, but it also determines the pressure gradient and your mean pressure gradient as well. All right. So determine those pressure gradients. Okay, determine these parameters. And then again, because we have mitral stenosis, there's a good chance that the other valves have stenosis as well. So take a look at those with your Doppler. And then look for any coexisting mitral regurgitation via your Doppler as well. And then lastly, we'll get into the color Doppler for a couple slides here. I think this is the last slide. So in the color Doppler, you'll see a narrow flame-shaped turbulent jet at the valve opening that goes into the LV, and like Kelsey just pointed out, typically directed towards the lateral wall in the 4-chamber. So it's going to come out. So keep in mind that these images on the bottom, these are transesophageal. They're showing PISA measurements. and distinctly showing the difference between adjusting your color baseline. I'm just showing you these pictures just because. But we're looking at it from the 4-chamber view typically. So they're talking about that confluence of flow that becomes like a flame-shaped turbulent jet going into the left ventricle. And again, you're going to notice that at first, when we have normal hearts and you have normal flow, you typically see flow just dumping across. You don't get distinct jets until something's not right. Okay, so in echo, when we start to see formation of jets and things coming together, usually something's not flowing correctly. Okay, when it comes to the valves and stuff like that, that's when we start to see regurgitation. That's when we start to see stenosis starting to form. All right, we're going to evaluate the degree of narrowing by the vena contracta. So again, vena contracta, we can take this. Now we did our aortic in the parasternal long axis view. We do measure the shortest height of that from a perpendicular perspective to the jet. You're going to find in the textbook, they often do this from an apical 4-chamber view. That's fine. Just realize that the best way to measure any vena contracta is to be perpendicular to the jet. So I would suggest that the parasternal view might be a better perspective to measure that. But go with what your lab does, because I do notice that in the textbook, they show it measured all the time from apical 4-chamber. I don't personally agree with it from a physics standpoint, but that's beside the point. All right, so PISA can be used as a method. So it's the same PISA formula that you use for looking for effective regurgitant orifice and stuff on a regurgitation. But it can, like I say, PISA measurement itself, it's the same concept. You're still adjusting your color baseline to accentuate your shell. You're putting the measurement of that shell, that radius into the formula. You're taking that velocity off of your lower end of the color Doppler bar, and you're plugging that into the formula. Again, the system's doing this for you if you're doing it on the calculation package. And then you're taking your continuous wave through the jet and then tracing it. In this case, it would be through the mitral valve jet, and you would trace the whole EA combination and plug that into the formula, and that would calculate out an actual orifice size or your cross-sectional area or your MVA, mitral valve area. So again, it's not commonly used for that. PISA is most often used on mitral regurgitation, but it certainly could be for this. And then lastly, just determining the presence and severity of any coexisting mitral regurgitation. And that is the mitral valve stenosis. So tomorrow we'll cover mitral regurg. So it'll be a similar idea to the other valves. So it shouldn't be too much surprise, good review. Any questions on mitral stenosis at this point? So I think the more pictures you see of it or more video clips, the better. You know, again, you can just Google stuff. So let me just do, just to see what we come up with. I'll do echo mitral valve stenosis. And I'll try to get it in GIF format so you can see the clips. Okay, so you'll start to see some of these. Here's one, a good classic one. Okay, so you see when that opens, you see how that has the hockey stick appearance. Stop beating on here. Yeah, that only played once, that's all right. There's long ear, so that's basically a normal valve there. That's big. So other things that can cause it, so again, it could be the chordae tendineae, it could be thickening of the leaflets at the tips, it could be thickening of the from the calcification of the mitral annular calcification working its way inward. It could be a parachute mitral valve. So that is a valve that has one papillary muscle and it has just one opening. So it acts like a restricted valve.
What wall is that papillary muscle typically on?
I'm not sure. I think it varies. I think to start with, it's already quite rare. to have a parachute mitral valve, but I'm not sure it has a distinct location when it does occur. It could just be any location. That's a cool one. Beach ball inside the atria. What did I call that mass?
Myxoma?
Yep. So myxoma, they typically can be quite large. Pathologically, they kind of look like little clusters of grapes that make it up. But again, this can be protruding through the valve, causing stenosis. These typically attach to the intraatrial septum via a stalk. Here's, I think, a good short axis one. You can see the thickness of the valve leaflets in this one. I think that just might be a still picture.
It got a lip injection.
Yeah. Yeah, it looks like Botox on there, doesn't it? That's funny. Yeah, you get the idea. So I just would look through some of these, just Google some pictures, see what you can find. Some of those other websites that have some echo stuff, I think those are helpful. Yeah.
Scott,
Yeah, Kathleen, go ahead.
I have a question about regurg. When would we use pulse wave on regurgitation?
You're not going to use it for the regurgitation itself on a mitral valve. You're going to use it for the E and A. You're still going to use it to evaluate your diastolic function. Is that your question? Is on the mitral valve? Or you're talking generally?
So when we were doing aortic, you had the section on pulse wave, but then Tammy said that we never ever use pulse wave for regurgitation. So I think we're kind of confused about that.
Well, you can, if you're looking at a severe regurgitation and you're doing it in the descending thoracic aorta, you can use CW or PW is acceptable to use there. And you're just looking at the time that the diastolic flow reversal occurs. If it happens all the way across the cycle, across diastole, then that indicates that you have a severe aortic regurgitation. So that's the only place you would use it for aortic.
Is that so we would not use that for mitral valve or tricuspid?
Correct, you would not. I mean, there's always exceptions, right? So you could use pulsed wave. So would there be any situation with a severe mitral or tricuspid regurgitation where I might use pulsed wave Doppler? The answer is yes, but it's not on the jet itself. Can you guys think of a time when you would?
Is it when you have another pathology going on?
No, it's going to help to diagnose the severity. So just like I'm taking my pulse wave way past the aortic valve for regurgitation, so we take that in the descending thoracic aorta, where might you take a regurgitant pulsed wave that might tell me some information about how severe that jet is?
Pulmonary vein?
That's not inside. Yeah, so it's pulmonary veins. Yes. So regurgitation happens during systole, so I would get a depressed or reversed S wave, both in the pulmonary vein and in the hepatic vein. So yes, that is one circumstance you could. So there are times, yeah, you can add, but that's secondary information that adds to my diagnosis. It's not of the valve itself.
Oh, that's the clarification that Tammy was saying. You would never pulse wave the jet itself. Not that
Correct.
you would never use pulse wave to prove it. It would
Correct.
just be a secondary type thing.
Yes, yes.
Okay.
Yeah, and theoretically, we could do the same with pulmonary arteries, looking at pulmonary regurgitation. The fact is we don't see very far out the pulmonary arteries because it branches off quickly to the lungs, which, obstructs our view. So theoretically, you could do it there too, but we just don't see it. So we wouldn't normally do that. Does that answer your question, Kathleen?
Yes, that was helpful.
Okay.
So thinking of the competency exam, so we just need to be thinking of obviously what we'll be evaluating being like 2D, M mode, spectral, pulse wave, continuous wave measurements, and then what primary reasons would be causing a stenosis or regurgitation, and then what secondary reasons may be causing each also.
So that's kind of what I do. So again, just to reiterate, the point of doing it is to show that we have the critical thinking skills to be able to understand why. So really, if you could do one thing for me, it is to answer the why. Why do I take this picture? And what pictures are relevant to that pathology, both directly and indirectly? The direct ones are more important. You got to have those. Like, for example, if I'm doing aortic stenosis, I've got to have the stuff that I need for continuity, which is LVOT diameter, LVOT pulsed wave tracing, VTI, and I got to have my VTI of the aortic jet itself, and or at least the max velocity. If I don't have those three things, I didn't do my job. But again, looking at chamber size and things like that, beyond that, those are certainly contributing factors that help to prove or disprove my diagnosis. Taking, for example, if I've got those big regurgitation, say if I've got aortic stenosis, does it help me a ton to have a pulse wave of the pulmonary veins? Long term, I could probably see some signs of it, but not enough to really tell me the story. Okay. So what I'm really looking for is to answer the why. Why do I take this picture? How is this picture relevant to that pathology? That's really what I want answered above and beyond anything. So that's kind of the main point.
Yeah, she was just saying it really kind of gives brownie points if you can give us little extra floofy reasons, like what else could happen if, this goes on long term.
Yeah, so we're trying to determine your thought process behind your pictures. We certainly have people that throw pictures out there just at random, like we get people that almost try to burn through a protocol in 15 minutes just to make sure they got everything that was relevant. Does that tell me you know what you're doing? No, it just tells me you're trying to rush and get everything that's in it. So what I want to try to avoid, and I will intentionally be a little bit evasive on this question, is I want to avoid people coming up with mini protocols, because when we get stuck into protocol thought, we don't think about why we're doing it. And so, I mean, yes, it can help you, but you're still going to have the problem of not being able to critically think your problem. Okay, so try to, I mean, it's fine to make up protocols. I just want every image you take to be able to justify that picture.
About how long is this going to last?
15 minutes. So we're not going to have a ton of stuff. So if I'm doing it, I typically have you get I need to have something to grade for the lab. Like if you're doing it live scanning, I need to have something to grade each type of thing that you scan. So I need something in 2D. I need something to be measured in 2D. I need something in M mode, something to be measured in M mode. I need pulse wave, CW, well, spectral Doppler at least. Those things. So I need to grade each type of mode use. So 2D, M mode, color Doppler, spectral Doppler. If there's measurements associated with those, I like to have at least a couple of measurements to do. That might be part of your pathology expectation, or I might just add an image or two to that so that you can give me something I can grade those skills. Because I am grading skills, but I'm also grading thought process and that as well. And then I usually ask a couple of extra questions also, basic questions. But you have 15 minutes to do it. It should be plenty of time. I know it's stressful, but it's not that bad. Nancy?
So are we scanning it and talking through it, or are we just, how does that work?
If it's me doing it, so again, I say that because it's Tammy and Tyler doing it.
Yeah,
but
and
they
we
know-
shouldn't be talking to you about this, right?
Yeah,
We should be
well,
talking to them about this. You're not going to be there.
They're going to be the ones grading it for sure. And I've told them how I do it. Tammy has worked with me in the past, so she knows how I think about it. And we do it, and we actually grade it together. So if I do it, I could do it written or I can do it scanning. If it's what I usually would do is I'll have Tammy first go home because she was my second person when I was doing it before Tyler was here. I would have her go and evaluate it without me giving any influence, and then I would I would grade it on my own without her influence, and then we sit together and we discuss it together, and then we put our grades together. That's how I did it. There always was one second attempt. So if somebody bombed it, they could redeem themselves. But I also average those grades together. So if you bombed it miserably, and that only happens with people that honestly don't prepare at all, they just come in thinking, I'll just wing it. And if I get it, great. If not, I'll just redo it. You could bomb it so badly doing that method that you can't statistically pass. But those that prepare don't have that issue, honestly. But yeah, talk to Tammy and Tyler. They're the ones going to be running it, but they do kind of know my methodology, and I'm happy to tell you how I do it. I typically like to have a few echo views. So again, I like to have something to grade for each mode type of ultrasound that we normally use. I like to see some measurements. I like to see some M mode with measurements, 2D with measurements, spectral Doppler with measurements, etc. And again, those are usually pretty quick.
Okay, thank you.
The main points by far is the critical thinking aspect. It's being able to put together and do basically the right stuff. And do you have to get completely everything that applies to that? No, not at all. But again, if I do an aortic valve as a good example, if you fail to get the continuity equation complete, because there's only 3 things you have to actually get from echo, good luck. Yep.
Scott, is it
Yeah.
possible for us kind of having the paper where like information what we should know for this exam? Like for aortic stenosis, we need to know this. And
you could put it together. I mean, I suggest on each lecture as we go through, take notes, because I will tell you as we go through the lecture, it's like, what's the take-home message? If I go into an echo room, what do I need to get? Kind of stuff you want to see. I think this book is really good if you don't have it, because this basically tells you when I go in the room, this is on the M mode page. These are the things that apply to it. Not everything on there is going to be applicable to every exam, but definitely look through that and kind of take the main points. Okay, so you can do that. What's nice about this book too is it gives you pictures of it. And I haven't actually tried it, but earlier in the book, let me see, there's some places in this book, it actually has QR codes. I don't know if you see that. Some of these, the new book has some of these QR codes. I haven't gone to them, but if you just take your camera on your phone, your smartphone, and just take a picture.
I've gone through them. They give some of
website.
them, they give kind of like a small video clips, like for example, for pathology or something. It's very interesting.
Yeah, I think that's great. So use that, I think, is a good resource. When I was scanning and I would come across something that was rare or I didn't come across very often, I dug this book out, and because I would scan maybe once in a year, I'd scan something in there. Or I remember talking about it once in school years ago, and all of a sudden I had this case that has that pathology that's very rare. I would grab that book and I would read through it before I went into my case, and I go and find, it's like, what do I need to know? And I quickly go through. It's like, okay, this is the history, this is the etiology, this is what I would see on MRI, CT, Nuke Med. This is what I need to get in echo. This is what I need to measure in echo. And that's what I would take into the room and do my study, so that I could have a really quick reference to be like, I need this, and that's what I'm going to go get. So I love that book. Great book. Yep.
I know that you like to be evasive about this and you don't like to provide a resource, and that you want us to create it ourselves. But I know that myself and my classmates are very good at learning something when someone is present, learn this, and then I will. And then I by doing that, I have a clear expectation of how what I'm learning is what is aligns with what is expected, because I'm not going off on a wrong course, because I'm finding the answers on my own.
Right.
So that's why I think maybe you've heard a few of us say, is there somewhere I can look And I think what you're calling it is a mini protocol. I'm not sure. Anyways, that's,
Yeah. So
we're good at learn this. I will learn it.
right. So, I mean, I am intentionally invasive on some of that stuff because I do want students to dig in because you really don't learn anything until you dig in yourself. Okay. Having said that, as we go through each of these chapters and each of the pathologies, I am certainly happy to discuss the things that are relevant to that and the echo that we're doing, how to connect that to the lab. So if I'm not answering that during the lecture, ask me and we can certainly, I'll walk through it with you after we've discussed it. But again, the idea of the mini protocols is because I had students in the past that ended up just putting a bunch of mini protocols together and then they really didn't understand what they were doing. They would just go into the mode of, oh, it's that protocol. If we were going to do that, I would go into X-ray or a different modality that just follows protocols. The reason I do what I do is because the doctors want they want more critical thinking techs that can think through the problem and understand the why of what they're doing.
Right,
Is it
I
the
understand
best
that.
method?
And
It's probably not the very best method, but and some people do very well if I give them a fairly structured set of instructions and others don't. That's just how I choose to do it. As far as the protocol goes in their protocol test, I did tell Tyler and Tammy it is up to them. If they want to change it and do it some totally different way, they can totally do that. That is their class. I give them the freedom to do that. But they do need to do a competency of some kind. Okay. But yeah, when we discuss this, anytime we do a lecture, what I want you to get as a take-home message is, what do I need to get when I go in the room? That I need you to have. Okay. Good. A little bit less looks of panic. That's good. Any other questions?
So like if we present you with like an image of like an aortic stenosis and we give a list of things that we know, can you give us some more input of like what we're missing?
Sure. Yeah, if you give me some ideas, I can go over that.
Okay.
In the test itself, we don't typically help the student necessarily. You'll be given the information and then you go scan it or you write it out or whatever it is. It won't be interactive during the test, but before the test, absolutely happy to go over. If you have questions about stuff, we can go over it. We can tell you what you're missing. We can tell you, I would do this differently. I would do that. This applies. This doesn't apply. Absolutely. Sarasota, yeah.
So I have that coworker who has a congenital heart deformity, and she said she would come in and let you scan her. But if you can do like a whole protocol and put it on a CD so she can take it to her doctor.
Yeah. So what do you know what kind of congenital thing she has?
I'm pretty sure she has a bicuspid valves.
Okay. Yeah, I'd be happy to scan her personally, so we could just arrange a time for that, and or Tyler or Tammy, if they're willing to do it, any of us could certainly do that. But yeah, I'd be happy to do that.
Great.
Yeah, and I like when people come in from the outside and we have actual pathologies because we can scan them and then we can put them on the database so that we have a good reference to go back to and teach from. That's awesome. Kelsey?
Yeah, I was just gonna say, I wonder if she'd be comfortable with us like learning from it.
Yeah, some patients are okay with other students being in the room, like a group of students, and some aren't. So either way, we could handle it.
She said she's used to it.
Yeah, so she wants to come in during the full lab, and if I'm not going to throw Tyler and Tammy into it unless they want to, because I mean, Tammy being pediatric for one is she's very good at peds in that she scans differently than we do because they scan sector sizes, they're upside down and stuff like that. They're actually right side up. We're the ones that are upside down. But I don't want to throw them into that because they are professionals in the field. But yeah, if they're willing to do it, any one of us could do it. Absolutely. And yeah, we could burn them a CD when she's done. We just won't diagnose it officially. All right.
Right, we're not doctors.
Nope. We need to diagnose like doctors, but we will get no credit. We'll get a high five from the doctor. We'll say that. Good. All right, we'll let you guys go for the day. I think we're good on time. Awesome. Have a good one. So we will cover mitral regurgitation then tomorrow.
Thank you, Scott.
Good. Take it
Thank
easy.
you.
Thank you.
Awesome. Thank you.